First of all, thank you very much for the invitation. I have a disclosure, namely that I believe in specialization and training, and that's the best for our patients. So that's my main. I'm terrible biased. So when you look, at least in my language, I know Britain is different. Britain is money-driven much more than the communist country of Denmark. The cost to society, one thing is the money side, but the cost is also all the suffering. And the cost-benefit is trying to get it right between how much money we use and how little suffering that we can get. That's the way I look upon it. I'm sorry. You see, the thing is, time is changing dramatically, and in my country. So here you see the 30-day mortality after resectional surgery. When my older brother was born, it used to be 30%. But we were very specialized. Each hospital treated 2 cancers per year. In 2005, I was nearly killed because I said, we can't live in a society where the 30-day mortality is double that of Sweden, 6.7%. And see what has happened. We have closed specialized rectal cancer, less units. In my own area, 2 million people, we have now 3 units. So we have about the same number of cases as the very highly specialized Cleveland Clinic. And sacral nerve stimulation, 1 side, pelvic pouches, 2 sides. In my region, we are the only one who does prolapse surgery. And that's because it's the way the surgeon thinks it should be. So what has happened? 1.4%. And that's not because we are not operating. I don't know why, I can't tell you. It's because we are dedicated, we are focusing, we are doing better, and our long-term survival is racing and racing every year. We are probably the best country now with the best survival rates in the Scandinavian countries, better than Sweden, I'm sure. And here's the annual. So in the good old days, what is the cost? Is it a cost to kill a patient by surgery? It may be cheaper, basically. You don't have to pay the pension. So it's a cost and suffering. The cost is hopeless. So therefore, but we have created a problem. Our patients start to survive, and we must, and I agree, that is the focus, the survival, but we must keep the suffering down. So I'll go through the costs. We do a lot of follow-ups. We presented in Berlin recently all the evidence for all the follow-ups after treatment. And generally, there's hardly any evidence. All societies do it differently. The only evidence there is that there apparently is a benefit of combining CT with CEA. We have done the big trials in the Scandinavian countries, the Colofold trial. The final thing has not been out now, but there's no benefits of doing more than 1 to 3, 2 times at 1 and 3 years. Then we're trying to do the most stupid trial in our area, the Furka trial. And we thought, instead of, we're pressed all the time, don't look at your patients, don't look at your patient. So we thought maybe it's much smarter to randomize it before they close everything to figure out. So that's the Furka trial. And the thing is, there's poor level of evidence for what we're doing. We don't think about how the patients are, and we don't involve the patients in anything. I mean, they come in the outpatient clinic and the surgeon put up a scope and take it out, kick it out, and that's the way it is. So we did this trial, and since we have specialized, we have within no time, and we'll be finished next summer, randomized 354 patients. And about 70% of all the patients want to participate. And we are most interested in the psychology of those who don't want to participate. So these have had an R0 resection, a curative R0 resection for rectal cancer, and we randomize them in 2 arms. One is that we do all the usual stuff. And the other ones, we talk with the patients. They get instructed, we tell them, if you have this and this symptom, call us. If you have these and these sequelae, call us. And then we do the CEA and the CT scan. I'll bet you, it's much cheaper just to do it the way we are, and I'm sure that our patients would be more satisfied, but it'll take a little while to know it. Okay. Laparoscopic surgery, we have changed. Basic resectional surgery now in Denmark is nearly always laparoscopic. And in the same time, our mortality rates and survival rate has improved. We have recently looked into 2 aspects on a national basis. The risk of having surgery for small bowel obstruction and incisional hernia, peristomal hernia repair. It's so easy in our society, we just, mix various things together. So here is the nice thing. Laparoscopic surgery decreases significantly the risk of having surgery for small bowel obstruction, and on top of that, the time at hospital and etc. was shorter. You can look into it. Incisional hernia rates, surgery for that was about the same level, maybe a little less, but we had a little worrying higher risk of peristomal hernia rate repair. Is that because, strange thing is happening on the abdomen when we do it laparoscopically? Is that because we are not doing it correctly? Is it because the threshold for repair is different? I don't know. But the key thing, that's all the harms we do. So first of all, look at, and these quality of life questionnaires are fantastic. Very, very good, but they're not useful in clinical practice. They're too complex. You can't use it, you can't interpret them on an individual level. So you have to have something simple. Do we really have a problem? And then you just check it. And you need to have something simple. Simple surgeons need simple tools. And then we have to test it. And that's the last score, very, very simple. In fact, we talk with the patients before we ever send out anything. And then we cross the machines and did that some years ago and randomized it one way or the other. So we have a development and things like that. You can read it. And it's very, very simple. The 2 key elements are the clustering and the urgency. And when you think about it from the patient perspective, if you, Simon, are having urgency and you don't know if you have to rush to the toilet, and then you come back and try to sit and relax, and then you never know if you have to rush again, then it's no fun. So that's the key element. And even the radiation oncologists didn't understand it. The surgeons didn't understand it. And I knew it. We have tested it because I didn't understand it. I think I'm as smart as all the other ones. So we validated and it fits well. And we have used it. Basically, I think it's translated into 30 languages. Most recently in Brazil, where they hardly can read. And then we have, that's true, and taking it up against quality of life, even there it works. We have looked at it prospectively and things like that. This is a very simple, good screening tool. And here you have it. You have seen it before. So since it works so well, and we just did it in a little more than 1,000 Danish patients, we thought we can't find out something new. We send out to all surviving colorectal cancer patients. So we send out to 22,000 or something. Response rate very, very high, so that we can look into various details. And so based on that, we thought maybe wouldn't it be worthwhile to know what bothers a patient with a colostomy? So we developed a colostomy impact score, and now we are trying to do exactly the same with the last score, trying all over the world. Is it different in Muslim countries? I don't know. Is it different in societies where they don't pay for all the stomach care? I don't know. So we'll know in 1 or 2 years. We developed a pain score that we are going to use for some prospective studies in Denmark. Very, very simple to figure out and again score it so we have something to use for. And we have also very recently developed a female sexuality score based on the other ones. This is more simple. And at the top, we have added a little bit, are they still sexual active, or have they stopped having sexual activity after the treatment? And we are validating that now in Sweden and Holland, and we'll use it prospectively. Everybody who wants to join us, everybody is welcome. So we think that it's smart to have simple prompts. The last score, everybody can fill it out in 30 seconds. And when you test it again, it's quite stable. So we use all these things. We have our urologists helping because we have all the fancy urology thing from all cancers, including polyp cancer. So we'll try to get something simple for these two so that we have simple tools that we can use. So if there is a problem, what are the risk factors? And you have heard about it. The key thing for Lars is still surgery. Don't forget resectional surgery. I mean, blame the radiation oncologist for everything, but surgery is still a major problem. I wanted to show this to you. This is a very small, fascinating study that we did, where we did post-operative MR scans and measure things. We didn't care whatever anybody has written. And see, if you look on the top thing, that is surgery alone. And tell you, in the baseline population, about 15 to 20%, if you send out a questionnaire, about 15% would have major LARS. I mean, some bowel problems are very, very common. So if you safely can leave 4 centimeters of the rectum with surgery alone, you don't get major bowel symptoms, but safely. Don't try to fuck it up and leave. I'm very, very strong on this, that you don't start to make short resections to get better function, because the patient will get local recurrence. So it should be appropriate. On the other hand, if you irradiate, doesn't matter whether you leave 0 centimeter or 8 centimeter, at least when you combine it with resection. It may be and likely very, very different if you do local treatment and no surgery alone. So then you can predict it. The smart British guys have helped us develop the polar score so that before you start any treatment. You can go in a smart diagram and you can use an app. You can predict the risk. And Battersby, he told me that, do you know why you should have this score? I don't understand it. It's to protect you against the lawyer. From my point of view, something else is much more important. I mean, if you a priori can predict the risk of having major loss after neoadjuvant therapy and resection, in my opinion, many more patients should have an APR. I mean, we usually don't do it. I'll tell you, in 1 year, I can tell you whether, for example, people who are working are more likely to be back to work if they have had neoadjuvant therapy with an APR than neoadjuvant therapy with a low anterior resection and joined up. I think they're more likely to be back to work. I don't know it. I can tell you in 1 year, because we just joined everything up. What will waiting? You see, if people should have neoadjuvant therapy, I think that this trial with neoadjuvant watch and waiting is very, very fascinating and interesting, because then you avoid the worst of both. On the other hand, in the STAR trial, I'm really in doubt. That's the reason why we take part in this trial, because here you go into smaller tumors, and if you end up having neoadjuvant and have to resect, then you must be worse off. So, treatment. We must recognize, so all our patients, that's what we are going. Next Tuesday, I'll know if we get a big grant, then we'll set it up on a national level. All the patients should have these problems. At follow-up, all patients should be recorded with these things. All patients who has major symptoms and want to have treatment should be treated, of course. And we have two different strategies. One is the simple surgical strategy with nurse-led clinic through our pelvic floor unit. Those with diarrhea, I think it's more likely and smarter to give it a Jervois type of approach. And we have done this at our own unit for a period, and about half of our patients with the diarrhea associated, we have had more success with the other ones. We must understand the pathophysiology. With resection alone, it's the level of the anastomosis and then some funny thing that's going on in the colon that's properly denervated. If they have neoadjuvant therapy, they don't know what's going on in their pelvis. You can more or less put in hot water and burn off everything before they recognize anything. And I know it because we have done it. Diverging stoma, it is a concern, but we have this problem with the leakage rates. And if we can get less leakage and have less diversion, I'm sure it's better for the patient. The dynamite is resection and neoadjuvant radiotherapy. Got a lot of problems. I'm not saying that we shouldn't do it, but we should think about it. And we should try to help the patient afterwards. So, my vision, we should think about what we are doing. We should give the patient an appropriate follow-up. Then we would still save more and more patients. We will have less suffering, with therefore less cost. We want to have developed these prompts to all pelvic cancers, because it's not only colorectal, it's bladder, prostate, it's cervical cancers, And we will try our best to set up a multidisciplinary program for all these cancer in a multidisciplinary setting to improve the outcome of our patients. Thank you.